Welcome to this morning's second session on the question, do current efforts to involve patients and the public in rapid evaluation go far enough? I'm very pleased to be joined by three speakers who actually do know something about the answer to this question. I wouldn't claim to do that. Anyway, my name is John Sussex. I am a senior health services researcher at an independent organisation called RAND Europe, a not-for-profit policy research organisation. And we are part of the BRACE Rapid Evaluation Centre funded by National Institute for Health Research. So my job is to chair this session and to moderate some questions, which I hope that you and the audience will all be asking. I think by now, everyone's very familiar with the question box at the bottom of your screen, and please use that to freely give vent to any questions you have for our speakers. Now, our speakers are in order. There'll be Jeremy Taylor, who is the NIHR Director of Public Voice and was, before he took up that role for many years, the Chief Executive of National Voices. He'll be followed by Rochelle Gold, who is NHS Digital's Head of User Research. And third, and certainly not least, we have Professor Sophie Staniszewska from Warwick University. She has a chair in patient and public involvement and experience of care, and specifically in the Warwick Research in Nursing unit within Warwick University. So I'm going to pretty much stop it there, other than to observe that the question whether efforts to involve patients and the public go far enough is something that obviously is asked of, we ask ourselves as researchers, those of us who are researchers, and is asked frequently all the time, was asked before the pandemic, is still being asked now, and I'm sure will be asked when the pandemic, as we all hope, is over. So I think, in my mind, though we're asking this question in the current context, I very much have in mind what is the answer in general. Do we put enough effort into involving patients in the public? I rather suspect the answer is no, but it'd be very gratifying if someone thought the answer were yes. But rather hoping for rather more than binary answers and with some thoughts on do current efforts go far enough, I'd like to first hand over to you, Jeremy, to give us a few minutes of your initial thoughts in response to the question, do current efforts to involve patients in the public go far enough?
Thank you very much, John. Because of my job being Director for Public Voice at NIHR, I sort of have a kind of instinct to believe that the status quo is never satisfactory. So my provisional answer is no, current efforts don't go far enough. It obviously is partly an evidence question. Do we know how good current efforts are? And actually, probably we don't, and that's part of the problem. We don't have a good enough evidence base about how effective PPI is and what is coming out of it. It's also a values-based question, where would we settle for enough? I think we shouldn't settle where we are yet. So I want to say a little bit about patient and public involvement in research in general. I'm not an expert on rapid evaluation, but I know a bit about patient and public involvement, a little bit about where I see the scope for improvement. I'll try and relate it to the rapid evaluation world, and then a little bit about the impact of COVID-19. And it will be very cursory, obviously. We've been asked to speak to 5 minutes each. So why bring patients and the public into rapid evaluation? Because I think they're probably pretty important contributors to questions about what are we going to evaluate and how, relating to Judith's quote about not skimping on scoping in day one. The questions about what are we actually going to ask in the evaluation? How do we interpret the answers? And then critically, what do we do with the answers? So in short, I would see public involvement in research in general, rapid evaluation in particular, as being a really important way of ensuring that the enterprise aligns with what matters to patients and the public. Interestingly, I thought Tricia Greenhalgh, again in day one of this conference, kind of made the case very powerfully when she was talking about the importance of democratic evaluation based on inclusivity and the quality of the dialogue, and also utilization-focused evaluation being energized by the question, who is going to use this evaluation and what purpose? Nothing like having patients and members of the public in the room to focus you on those sort of practical questions about the ultimate use of the research. In my personal experience, patient and public involvement in research can be very influential in shaping the study, in keeping it grounded in practical realities about people's lives and health. It can improve the conversation and help to reconcile competing views. And I think it can strengthen the moral imperative to actually do something with the research once it's completed. In my day job at NIHR, I'm working with colleagues on some areas for improvement in patient and public involvement. NIHR has been committed to it from the outset, but we can't rest on our laurels. So we're looking at where can we strengthen public involvement, and where can we use the learning from COVID-19 to energise that endeavour. So here are some questions that we're asking. Lots of people are asking, actually. Do we bring public contributors in early enough to be able to shape the research in a meaningful way? Do we sort out the practicalities that make that possible, including things like payment, both in terms of quantities and speed of remuneration, and the interface with complicated things like tax and benefits? Do we draw on a diverse enough pool of contributors? And once we have people to work with, is it a partnership of equals, or is it more like public members making a marginal input into a professionally led enterprise? And finally, and I think this is a point that may be taken up by Sophie, because I know it's something that she and I have discussed a lot. Do we learn from the experience of doing PPI? Do we build a body of knowledge about what works and why and how, and what doesn't work and what the struggles are, and how we can overcome them? I'm not sure we do that well enough. So therefore it becomes quite difficult to answer the question, have we gone far enough? Because often we just don't know. So against those questions, I would assert that there probably is room to go further. I suspect, particularly in the rapid evaluation scenario, limitations of project time, of staff time and resource are often obstacles that get in the way, and the more rapid you have to work, the harder it is, I think, to ensure that you can have meaningful public involvement. Interestingly, COVID-19, I think, has thrown new light on this whole agenda in a number of ways. A lot of research was put on pause. It became more difficult to bring public involvement into some of the urgent public health research that was commissioned and funded at great speed. The HRA noted that in the first wave of urgent public health studies that were coming to them for ethics approval, the amount of patient and public involvement went down very sharply. But it's now built up again, partly as a result of strong messaging from national bodies like NIHR and HRA, partly because the HRA set up a new matching service to enable researchers who wanted to find public contributors but didn't know how to put them in touch with people who could find public involvement members for them. But there are also examples where public involvement worked very well, despite the fact that it was online and despite the fact that it was very rapid. So I think that the pandemic has told us that you actually can work rapidly. But I think there is some evidence that where the public involvement has worked best, it has worked because it is built on a pre-existing set of relationships. And there's something about seeing public involvement as investing in the social capital that is required to underpin a collaborative approach to research. You can't do that project by project very easily. It's better to be able to build up the infrastructure of collaboration earlier on. And actually, one of the best examples I know, and declaration of interest, of course, because I used to be at National Voices, but the collaboration that is Brace includes a partner who is all about patients and the public voice in the form of National Voices. I think that's a very good example of kind of building the partnership into the infrastructure of the research enterprise. So those are my initial thoughts. I've probably gone over time and I'll shut up now.
Thank you very much, Jeremy. Thank you for the plug also about Brace. Yes, we have tried to get PPI involvement in the whole process of the centre. Anyway, I'd like now to thank you for all of that meat. There's a lot in there for people to ask questions about, and I've certainly got one or two. But I'd like now to pass over to Rochelle, if you could give us your few minutes worth of initial thoughts.
Thanks, John. I'd say my thoughts, echo a lot of what Jeremy has said. Where I work at NHS Digital, we work within human-centred service design framework, and that means our research focuses on understanding the needs of humans, people, everybody that a service, an intervention, something impacts, whether that be health professionals, support staff, patients and public. And then also looking at whether, when that service is out there, does it meet those? And whatever we do, we need to make sure that it delivers outcomes for patients, that it has an impact, that it's clinically safe. And intrinsic to all of that, and the part that often gets missed, is that part about the patients, their needs and experience. And we can't deliver those outcomes and we can't have an impact unless what we deliver meets the needs of those patients. They won't use it if it doesn't meet their needs. They won't have a need to engage with it. They won't take part. And if it's not actually usable for them, they can't actually use it. Well, it's just not going to happen. And we need to understand those barriers from the patient perspective, not just from the clinician, the professional, the researcher's interpretation. And I'd echo what Jeremy said is, can we ever go far enough in terms of including all the voices that we need to include in what we do? Without involving patients, in my experience, we have missed out on vital pieces of information about the way something is planned to be delivered or is being delivered that has actually exposed gaps in care, and that gap in care could have potentially led to clinical risk. So this isn't just about saying, making sure we hear patient voice. This is also making sure we are keeping them safe. Health professionals, clinical staff, the implementation perspective is really important, but we need to involve patients from the start as an equal partner from the start. And the speed at which we've been doing things, particularly in COVID and in terms of rapid evaluation, particularly in this space, has meant that I think the patient experience and the patient voice has been deprioritised. And it is really important that we get things out there to help in this situation, but deprioritising that patient voice is a risk. At NHS Digital, we've turned round evaluations within a couple of weeks, and we have included the patient voice in that. It's what we do, it's part of our practice, building up the body of evidence as we go along. I think someone earlier this week talked about rap sheets in terms of what they use as a tool to do that. But I think one of the things we're not tuning into, and I think Jeremy talked about it as well, is that when we do rapid evaluation and we do include the patient voice, there is a danger to include those that we can access most easily or have put themselves forward themselves. And what we're not doing is focusing on those seldom listened to voices. And I use the word listen to and seldom listened to voices is because it is not for them, it's not for people to make themselves heard, it's for us as everybody else to listen. During COVID, we've been doing robust research, turning stuff around in days, and never has the need to involve patients and the public voice been more apparent in terms of managing that risk and making good, solid, very quick evidence-based decisions. But the pandemic has impacted on particular populations more than others. And those are also the groups who are seldom listened to and seldom involved in decision-making and having their voices heard. So this isn't about having representative samples or representative people involved in the decision-making. This is about developing, as Jeremy said, long-term relationships with communities to ensure you embed seldom listened to voices into that scoping, that research, but also, most importantly, the reflective practice as us as researchers. And when I mean that, what I mean is actually going back to those people that you've developed relationships with through research and saying, what was the impact of my research practice on you? How is the way I do research, I collect data, impacting on you? What is the experience for them? So we actually improve our practice as researchers. So this is about also our researchers being part of those seldom or listened to groups, being from those seldom listened to groups, developing the diversity of our fellow professionals, the barriers to access for people to be involved in research, to be representatives of the patients and the public. It's about self-interest groups becoming part of the research commissioning and planning process. And it's something that ethically, as researchers, we all need to be doing, because our findings aren't robust without it. And with that, I'll pass on to Sophie.
Thank you very much, Rochelle. Thank you. And we're building up a nice pile of interesting issues and questions here. So thank you very much for that. Well, I'm sure we'll be having a good discussion shortly. But if I could ask now, Sophie, could you give us your thoughts?
Yes, absolutely. And I think my answer to the question is probably not in the same way as other speakers have said. And I'm going to cover a few key areas to provide a rationale for that. The first key area, Jeremy's already mentioned, is evidence. I guess my view would be, how sure are we that we are drawing on evidence of what good public involvement looks like? Are we conducting the public involvement to the quality we would expect? Are we then able to report it? And are we able to identify its impact and its contribution to the process? And I think without that, it makes it really hard to judge whether what you're doing is good enough. And also there is a risk that if you're not doing that, it's not adding to the evidence base, and effectively you're creating a form of research waste when you're not reporting it at the level we would ideally want. So I think there is something for me about developing the evidence base of public involvement in different forms of rapid evaluation to give us some understanding of how well it is actually working. I think linked to that is I guess the concept of complete evidence. Now in HTA, we have been working on this concept of patient-based evidence, and it sits alongside clinical and economic forms of evidence, but it's a sort of an acknowledgement that the patient element in its different forms has often been the poor cousin. We've given it much less conceptual and methodological attention, and we often criticise it for not doing its job and not being too tricky to incorporate. And that includes the evidence we might be using around experience or quality of life or patient-derived concepts, and also the public involvement that might shape that evidence. So we in HTA have been making the case that a lot of HTA isn't complete because it misses out quite significant parts of patient-based evidence, and it doesn't include patients necessarily in shaping the evidence it considers. So I guess there's something for me that maybe I challenge you back. Do you feel that rapid evaluation creates complete evidence? The other aspect of this, which is linked, is the methods by which you conduct rapid evaluation. My question back to everyone would be, how confident are we, or are we confident at all, that patients have been included in the development of those methods? So here I'm really talking about an area that is quite rare in health social care research. We rarely involve patients in developing methods, but that's often where we can build the public involvement into the DNA of research. And it isn't easy to do, and there's no funding for it, but actually it can move us forward in ways that really enhance what we do, because it gives us the space to think about how can this work and what is the public contribution at different points in that process. So there's something for me about that. The other element, I guess, is the process of rapid evaluation. It sort of sits slightly uneasily in relation to the things we know are indicators of high quality public involvement. So things like giving people time, development of high quality relationships, what we sometimes call having a deliberative knowledge space where people come together, they debate and they discuss, and new thinking and new knowledge emerges, which adds to the process. It makes it very hard when your foot is on the accelerator to make people comfortable enough in that process. So that may not be always the case, but it raises the question of, and I think Jeremy touched on this, and Rochelle, how much work have we done up front to create a good system for public involvement in different forms of rapid evaluation? So, and COVID, of course, has shown us where the cracks lie in our systems, our culture, our ways of working. Put a bit of pressure on it, and it gets a little bit squashed. So The project-based approach to funding does not help us with this. We need cultures, we need ways of working, we need those conversations with patients that say, from your perspective, what does good look like in public involvement in different forms of rapid evaluation? And I guess my question back to everyone would be, have we done that? Have we got that knowledge? Can we build on that? We saw that many of our public contributors, when they knew that research was urgent, rose to the challenge. But those responses were often based on pre-existing relationships. And I think there is a risk here that poor public involvement can harm people. It can cause, it can make people leave the field of public involvement, but it can also make people feel devalued. So I think we have to be really mindful of that. And I'm just checking the time, and it's 11 o'clock, so I'll stop there.
Thank you very much, Sophie. Yeah, so you're making some very strong and valid challenges, of course. So just to sort of remind the audience members, if you'd like to keep your questions coming in, that will be great. It'll make the conversation more interesting. We have the stream of questions is starting. I've got some thoughts of my own, but I'll hold back on those for the moment, because there's a very interesting question that's very close to my heart too, which has come up first. It's from Arna Walters at the Health Foundation, who I know is very much a quantitative researcher, but no doubt spreads much more widely than that. Anyway, Arna's question is I'm very keen to involve, to have more PPIE involvement in the research she does at the Improvement Analytics Unit. But there are two main challenges he sees. One, often programs that are being evaluated already exist, and the opportunity for patients to shape the intervention itself that's being evaluated is limited. And two, metrics that are important to patients are often difficult to include in quantitative evaluation, as the information needed is not routinely collected. So any thoughts from the panel on how to tackle these two challenges? So the challenge that the intervention is already there and defined in some to a large extent, and two, metrics of what patients find important may not readily exist. So won't always go in this order, but Jeremy, are you willing to have a first go?
Yes, with the health warning that I'm not a methodologist. But I'll try my best. I mean, yes, if you're rapidly evaluating an intervention and the intervention already exists, then there isn't much scope to shape the intervention. But it seems to me there's probably still quite a lot of scope to shape how you go about evaluating. Going back to what I was saying in my introductory remarks here, why are we evaluating this? What purpose is it serving? What questions are we going to ask? What are the things that are going to be of particular interest and relevance to patients and the public? I think they're pretty important questions anyway, and they're ones that are difficult to answer without having citizens involved in the conversation. I would urge Arne to do his best in that, recognizing there is still scope to influence the shape of the evaluation. In terms of metrics, I recognize the difficulty and I don't have an answer there. I'll defer to colleagues.
So what if I'll ask Sophie next if you've got any particular thoughts.
Yes, I guess. Yeah, interventions often are already developed. I guess we would reflect on that and ask ourselves why we didn't include patients in their development if it's targeted at patients. But even if it's targeted at services, that might have been something that we build on for next time. And I guess we still want to evaluate interventions in different ways from a public view. That is something that, people often build in terms of acceptability, relevance, appropriateness of an intervention. So that might even be part of your research study with study subjects, but there is still a public voice that can be woven through that evaluation with people forming judgments about what the data is telling us, how helpful is that intervention, is it going to do what the group thinks. So I think there's all sorts of possibilities that once you start thinking about where public involvement in methods and methodological thinking can happen, can create lots of opportunities. And I think you often need a group who are willing to travel that exploratory journey with you to really think through what that might look like. And in terms of the metrics, metrics as in, I suppose, quantitative data of different sorts. I am a firm believer that we are on a journey with quantitative data and public involvement, and I think there is a lot of possibility here. A lot of people are starting to get interested in interpretation of quantitative data. And I think the whole idea of patient important metrics is really important for us to adjust for the future. We've already seen it starting to happen in quality of life research, where metrics have been questioned because they're not necessarily of importance to patients. So what is it we're exactly measuring? But having just completed a study on public involvement in mathematical and economic modelling, and we've just published our framework that demonstrates its feasibility if you have enough time and you have enough of a journey to explore that. It was a bit of a Star Trek journey, and we did get there, but we gave ourselves space to do that exploration. So I think from me, sorry, this is a long answer, there's a real need for us to develop some methodological thinking, because I think that will really help us in the future.
And just to check, when you say us, there's a need for us to develop methods. So are you referring to the kind of the academic community?
Well, I think there's something about us maybe changing tack and working with public contributors to do that methods development and really challenge ourselves. And it can be done. And, you unravel a method and you work with a public group. And it's a bit like inserting the DNA of public involvement into the method. And then the next group who are coming along to do their mathematical and economic modelling can use, for example, our framework to guide their thinking. They don't have to go back to square one and ask that question, what does it look like in this very complex hidden sector, when we already have a framework they can use? So that has taken us a step on in that field, which is incredibly quantitative, incredibly complex and hidden, but we could still explore.
Yep, agreed. So I wonder, Rochelle, do you have anything you'd like to add? particularly from your, I think the researchers at least know NHS Digital as that wonderful library that contains all that juicy information, and Arne has pointed out that we actually really like even more different juicy information. The patient-focused metrics are probably a bit weak. Any thoughts?
I'd say you've got two really great experts as my colleagues on this panel right now, and so some brilliant advice there. But I think what I would add is you have to start somewhere, and sort of looking where you are now and saying, but we could have done it at this point and we haven't, so how do we do it now? Start somewhere. And if you start somewhere in terms of involving the patients in what you do, then you release the value, you show the value, and actually then next time they are involved from the start, or you show the need for them or the value in being involved from the start. And it's just about starting somewhere, doing something.
Agreed, yeah. So the questions, there's some very interesting questions lining up here. So there's one I'd like to put to you, all three of you now, which is from Jane Dunnage. She doesn't say which organisation she's from, but that doesn't matter. So her question is, how can patients be seen in more than one dimension? So not just as service users, and how can they become listened to as people with skills and ideas from other sectors and their own experience? And I wonder if that was particularly relevant to, maybe to Sophie's example about the maths and economics. Were there any people that she was talking to who actually knew a bit about maths and economics, as well as just being interested people from the public community? But so the question is, how can patients be seen in more than one dimension, so not just as service users? Would anyone like to come in on that? Rochelle?
Just actually from a personal perspective, my job is as a researcher, but I am actually a patient and public involvement representative on a academic research study. And certainly for me, that particular study, and actually the number of studies, recognise my skills as well to be involved in that. So I think it is out there. I think maybe we need to stop talking about people as patients and labelling them as patients. And actually, they're people. They're only patients when they are in a hospital being treated. They're actually people. And maybe there's something about vocabulary and thinking about how are we involving people and diversity of thought in what we're doing.
I think it's a really interesting question. Hello, Jane. I can't see you, but you can see me. I used to work with Jane at National Voices. There is a tendency to put patients in a box. They're the contributors of anecdotal, experiential insight, but they're not experts. And then if you dare to have expertise, like you have the skills you can bring from a current or former employment, then you're in danger of becoming a professional patient, and therefore you're not authentic anymore. Those dialogues play out, and I think they reveals binary thinking about people and their contribution. And the reality is that people have, they don't wear one hat. They have a range of experience and expertise and knowledge and insight. And I think the answer to Jane's question, how do we avoid the kind of trap of thinking in that binary way, is probably just to have good quality dialogue, good quality public involvement that involves creating a safe space in which people can have good conversations as equals. And if you get the process right, then inevitably the multifaceted nature of people's contributions can bubble to the surface. So I think probably the answer is the research teams need to avoid simplistic binary thinking and making assumptions about people.
Yeah. Okay, I think we'd all accept that. I wanted just to pick up, I was struck by something you said, Jeremy, in your opening remarks, where you referred to a good phrase, do we see evaluation and research as a professionally led enterprise? And I suppose as a researcher, yes, I'd like to think it is. And I imagine most of the other that we are in a profession and it is professionally led. But I'm assuming the point that we're all making is that good leadership involves. It doesn't just say, follow me. So I think, does anyone want to react to what I've just said? Because I'm happy to plough on with other questions. But is it okay that it's professionally led, I suppose, is my question.
I guess we could challenge that. We could think about, are there models of co-production here that we could, because I think co-production is a really important concept that values different forms of knowledge and expertise. And just going back to the previous point very, very quickly as well, in our study, people had different roles. They were patients, but they were public contributors as well. But the key thing was that the provision of knowledge to engage with the dialogue was really key. So giving people the tools they need to bring in their perspective was what made it work. So I think there is something about that. But there are areas of public involvement where research is user-led, because the people who are leading that research have their own experience and also combine it with academic knowledge. So there are different sectors. I think maybe we should be thinking about distributed forms of leadership here, and the knowledge that we get from patients and the public can complement the academic knowledge. It's different, but it adds something else that we often miss. So I think there are conversations to be had about what that could look like, because our core concept at the moment is co-production, and for co-production to work, there has to be some reciprocity and there has to be some valuing different forms of knowledge. So I would probably push back a bit about that. I know that it creates sensitivities and people really value their expertise, of course, but so do patients and the public as well as researchers. So I think we could have some really interesting conversations about that.
Yeah. I was expecting pushback, so you haven't disappointed. Thank you for that. But anyway, back to the questions. Some very interesting questions coming up here. So I'll pick one of them. There are lots of them. So one which is very pertinent to the moment is, how do you conduct PPI remotely? This is Rowan Dennison of the Nuffield Trust has asked this question. How do you conduct PPI remotely? Have any of the three of you seen it done well in the last year? I'm adding the word well into the question. Have you seen remote PPI done well in the last year? And if so, how was it done?
And I guess just
just
pick. So I have a number of projects with public involvement groups, all online now. And I think it's worked best when people have the relationships already existing. and we've got to know each other a bit, and we've been on a journey. It's been harder when we've set up new groups, but what we've tried to do is make space for people to get to know each other. So rather than launch into a project overview at the first meeting has become a getting to know you, and even things like, people introducing themselves and saying, reflect on one good thing that's happened this week and one not so good thing that's happened. Even at that level, people have started connecting, getting to know each other, and there's been a group bond developing. But I've also heard of things like people sending the same tea bag to everybody in the same meeting, so that everyone comes to that meeting with the same cup of tea. So I think people have been trying really hard to make it a good process, and there's been a lot of benefit. We've had international groups who would never have formed were it for not for COVID, but it is hard to do that high quality relationship building.
I love the shared experience idea. That's great. Yeah. Rochelle, do you have any thoughts on this?
Yeah, I think as Sophie said, it is difficult because face to face, there's a lot about the rapport building. I think we can also reflect on, as Sophie did towards the end, actually how the remote ways of working at the moment can actually break down some of the barriers. So people who may not normally be able to attend or take part in involvement activities now can, because it isn't in somewhere that's very difficult for them to access either physically or travel to, etc. So there are some benefits to it being remote as well, and I think in that we also need to make sure that we are not leaving behind anybody who struggles with being able to access things digitally. So there's pros and cons on both sides, but I think there are some benefits in terms of the spread of people who can now be involved in that involvement. And certainly from the research that we're doing, we are accessing people who maybe we wouldn't normally.
Very good point. Yeah. I mean, Jeremy, did you want to add anything?
I think most of the points have been made. It's important to recognise that not everybody can take part in Zoom meetings, and so there are still things like telephones and other ways of getting in hold of people, asking the public contributors who are on the Zoom meeting to make contact with other members of the public who aren't able to take part in that way. It's also important to recognise the financial and monetary barriers to participation. So some people, not everybody can afford the kit, the Wi-Fi connections. That's a barrier, and the principles around remunerating public contributors for their time apply whether you're turning up physically or you're giving your time online. So there are some practicalities that need to be thought through. But I think most of all, it's very easy to assume that because you've got a very large meeting, which is easier to, in some way, to convene online, that you may still be missing important people out. And so being thoughtful about who's not here and how can we get hold of them too, I think is an important principle.
You provided a very, very accurate segue into the next question I wanted to ask from the audience. In fact, I'm going to combine two questions because they are combinable. So the question is, can you, the panel, offer advice on how to find and recruit the right, in inverted commas, right members of the public to get involved? And follow that with a comment from somebody else who says we can be at least open-minded to the possibility that the public trust in public services may have declined during the pandemic. People may not trust public services as much as they did before. Does this make it even harder to involve those who are, quotes, seldom listened to? So this is a question about how do we get the right people involved, especially as seldom listened to people that we talked about earlier. So I'll throw that open to all three of you. I don't know who wants to go first.
I'm happy to go first. I think it depends how you define the right people. I think the right and recruitment, again, relies on good infrastructure within an organisation, good systems that need to be there before this comes up as a need. And that's not always the case if it's linked to a project. I think the right people are often people who bring, their own experiences. They bring a willingness to learn as well, and they bring a willingness to collaborate with others, and they bring a willingness to challenge us researchers, which is absolutely vital. part of the process. So I think when we recruit, we often will ask people just to answer a few questions about those sorts of elements, and we want people who will work together well, basically, and we will supply them with some of the information they need to be aware of. But it also depends on the type of project, if it's patients you're looking for, or if it's a broader societal group like public contributors who have a wider view. So I think there's lots of things to think about. And I guess the sort of public trust, yes, it may well have declined. I guess through those close discussions with potential members of a group, you would find out if there was a concern about that. I haven't come across that yet in the groups I'm working with. I think people, if anything, have a renewed commitment to be involved. They see the relevance. They want to make an important contribution to research and services. So, I've been really, really pleased with the response we've had to various calls for public contributors, but then we go on a journey together of learning, and that's, I guess, how I approach it.
Thoughts? Yeah. Jeremy, or
I think Rochelle's keen to come in, so I'll hold back and.
Right. Thanks, Jeremy. It's mainly on the trust point specifically. Yes, people want to contribute. Yes, people want to take part. But I think the evidence we have from our research is that actually trust has declined, and declined in some of those institutions where maybe it might not even have declined. The things like health and care and the NHS has been talked about as people really trust that as a thing, as a brand, as a place. But actually, a lot of that understanding has come from the groups that we are listening to. And when you talk to people from seldom listened to groups, what you actually find is that trust is not about the trust declining. The trust isn't there. So absolutely, I think there's a lot we need to do in terms of building that trust of public services right now, but with specific groups. And I think this is where that seldom listened to voice really is where we need to be focusing in relation to trust. It's a huge thing, particularly in this pandemic.
Yeah. Just a couple of things to add. I think researchers should be drawing upon the help and capacity and expertise of their public involvement or public engagement leads, if they have them, to support a process of reaching out. They should think about working with community groups and charities to provide a kind of trusted brokerage between communities that may not trust the institutions and the institutions who want to speak to them. So there's something about using civic society networks and the expertise of people whose day job it is to reach out and engage. I think the trust thing is a really big issue with some communities, and I think that the danger is that the research enterprise as a whole can be seen as a thing that sucks people up. We want to take from you. We need you. We want to exploit your knowledge and expertise and insight. So I think the research community also needs to think about what can we give back, particularly to communities that are disadvantaged. I've heard of some examples of where the relationship with the people who become the patient or public contributors started off in the form of education programs on self-management of particular health conditions. So you start with an offer of help, and it helps to form a relationship of trust, and on the back of that and the interest that is developed in research can come an involvement relationship. The problem is all that takes time. So it goes back to the things that I think we were all alluding to earlier, which is when it comes to finding people for a project, well, you wouldn't really start here, ideally. You'd start earlier with the building up of relationships over time. And I think it does take time. There's no shortcuts there, I don't think.
Yeah. Good. Okay, well, I've got another question here, which is, I apologise if it's kind of speaking to the researcher part of the audience more than others, but I think everyone should be interested in this question. It's questions, pick up a point you made, Jeremy, where you said that patient and public involvement seems to have decreased during the pandemic. We won't question whether that's true or not. We'll just take that as true for the purposes of this question. So is there a need post-pandemic, that world again, when we're out of the pandemic, for a renewed effort or something to get researchers to think more about PPI again? And if so, how? How should that be done? How should researchers be got back into using PPI a lot more than they are now?
It's a really interesting question, if you don't mind me starting. Actually, Sophie and I are both attending an event. In fact, we've been involved in the planning of it at the end of March. It's a collaboration between the NIHR Centre for Engagement and Dissemination and UCL and the National Coordinating Centre for Public Engagement. And it's an event aimed at researchers, primarily senior researchers, all about patient and public involvement. But essentially starting from the position that many researchers find this difficult and may not be entirely convinced that this is something that they really need to put all their efforts into. And we want to create a space where we can have those discussions, a kind of safe space for the discussions. Personally, I think there is the pandemic has given us an opportunity to kind of stand back and reset public involvement. Going back to NIHR, which has been a champion of public involvement in research, patient and public involvement since its inception in 2006, in large part due to the personal advocacy and passion of Dame Sally Davis, the first, the CMO at the time of creation of NIHR. That I think NIHR has done great work in embedding patient and public involvement in pretty much all the processes around all the way from inception to dissemination of research. But that's good. The downside is that it can be perceived as becoming a bit of an industry of going through the motions, and without sufficient attention to some of the questions that we've been exploring in this discussion around, is this really making a difference? Is it an equal partnership? Are we learning from it? Are we properly evaluating what works and what doesn't work? So I think there's an opportunity to stand back and to relate it back to the essence of why we do research. So what I'd like to see is a kind of development of a culture where patient and public involvement isn't the tick box thing that you have to do to get the award. It is one of the key parts of research and methodology, which is just as important as the statistics and the ethics and the methodology, the data analysis, and all the other things you have to get in place to do good research. So the more that patient and public involvement starts to feel like a critical ingredient in how you do good research and a discipline that you have to do and do well so that you get good research at the end of it, the less we will be agonizing about some of the issues that we've been discussing today. So I guess my longer term vision is that we've got more work to do to frame public involvement research as a critical ingredient in research rather than a separate but important thing that you are asked to do, which people bring varying degrees of enthusiasm and capacity to.
Very good. Yeah, I mean, I'd like to ask Sophie and Rochelle for your views. I can see that we're getting close to the end of the session. So if I could ask you to just kind of give us a 30-second answer on what should we do to get researchers to do more PPI post-pandemic?
Gosh, that's very quick. I guess, like Jeremy says, I think we had reached a plateau, and COVID has given us a chance to, in a sort of Thomas Kuhnsian type way of looking at the world of science and how it is revolutionized, to look at it afresh. And I think that we do need to do some fairly major building work around the cultures and the processes within our institutions that make it possible. And we also need to think about what the role of evidence and methods plays in this, and really up our game in relation to that. I think we've been moving along the same sort of plateau for some time. And I think that idea of seeing poor public involvement as a fatal flaw perhaps has come of its time.
Yeah. Rochelle.
30 seconds, really? Do you know what? I think in some places, just cutting off all research can actually be the thing that gets dropped when you're trying to deliver something. And so I think it's a perpetual problem about, people. I think people need to become aware. I think we need to do something more about the awareness of us as researchers not being the experts in this, and therefore us knowing why we need to make sure that patient and the public are involved in what we're doing. And I think we need to recognise our own shortcomings as researchers, actually, and actually develop our practice. And patient and public involvement is part of that practice. And if we don't do it, we are developing studies and research based on what we believe as somebody with a certain perspective on the world, and we need more than that perspective.
Got it. So it just remains for me to thank everyone. That's starting very much with the people who put in the excellent questions, which have prompted some very interesting and thought-provoking answers from the panel. And of course, to thank very much the panel, so Sophie and Rochelle and Jeremy. And we've hit 11:30, so I will now hand back to, I think Joe Ellens will be with us again shortly. But thank you, everyone.